Hello, welcome everyone. This is Nicholas Hall, founder of Graham's Foundation. I'm here today with Dr. Mohammed. He insists that call him by his first name, Khorshid, so I will absolutely do that. Khorshid, it's great to be with you today.
Thank you so much, Nicholas. It's an honor to be here and share the journey with your Ground Foundation.
Yeah, thank you. And so, what we're going to be talking about today in particular is I know a passion of yours, and that is brain health. And it's something that always kind of in the back of my brain, in the back of my mind when I was
Mhm.
there in the neonatal intensive care unit, and our surviving daughter had a grade 3 IVH bleed, and eventually had to have a shunt. And I always was just was always curious. Like, there's all these things that we're doing for the development of the baby, and yet the brain, like, it's you just don't know. And I always felt like, was there more that I could have done? Is there and so, that's now my daughter just turned 19. Holy smokes. So, and I know from a medical perspective, sometimes that may be a short period of time with the time that it takes to introduce and develop new methods and new procedures in the medical setting. So I'm fascinated to talk to you more about that. So maybe if you could share with our listeners kind of how you got fascinated by brain, the development of the brain and care for it. I know you're joining us from Canada. Now your accent does not give it away, by the way.
Yeah, hi there. Well, thanks. So my journey started. I'm Kurd. I'm from the northeastern of Syria. I never thought that I would come to Canada. I didn't know what Calgary is. My plan was to go and work in the Gulf area for a few years so I can afford a clinic and a house and then live happy ever after.
Mm,
But then it so happened in Saudi that I worked with a graduate from Calgary. He was a staff neonatologist from Saudi, a Saudi guy. And he just called me to his office and he said, I don't think you should stay in Saudi. I think you should go to Canada. And I can arrange an interview for you and then take it from there. And what's crazy about it was we study everything in Arabic. It's the only country in the Middle East, in Syria, we study medicine in Arabic. My English was close to none. And my interview was over the phone, landline, and my program director was a Scottish. So you can see everything.
Scottish? Did you
Scottish,
say
yeah.
Scottish
So I
English?
was getting,
Wow.
I was getting probably with like the line about 50% of what they were saying. So then I would pick up on the subject. The question is about, let's say, IVH. And I would say, maybe the question about IVH, the answer must be this. And then I would throw the answer. And sure enough, they took me, and I asked my program director after that, like, how on earth you accepted me? That was the worst interview I had in my life. She said, "Is your reference letters were excellent." And
Wow.
that's one thing now I advise my trainees, like if you are asking for a reference letter, make sure the person knows you and he writes you a very good reference letter. So anyway, so I came here. Again, the plan was the same. I'll do my 2 years of fellowship. Change my status from a registrar to consultant. I will have a better salary back in Saudi, and I will go back to Syria. And at the end of my fellowship, the 2 years here in Calgary, my section head and the program director called me to the section head office. And I thought I am in a big trouble. You being an international medical graduate, your English is not great. I thought I would be fired and they won't give me my certificate. And she told me that how about if we send you somewhere else to gain knowledge in baby's brain and then come back and establish the program for us. I said, okay, that's an interesting offer. And said,
That's a
yeah,
far different than what you were expecting.
yeah. So it's just keep my stay and training is keep extending because my plan was always to finish and then go back.
Right.
Then I thought about it. I said the brain is the forgotten organ. Like,
Mhm.
although it's the most important one, if you look in the NICU, you would see there are electrodes and monitors for everything except the brain. See
Yeah.
the heart, you see the oxygen saturation, you monitor the lung, all the graph and stuff. Nothing continuous for the brain except if we are in trouble. If we think that the baby's seizing, we'll put the EEG on, and that's like for 24 hours, 48 hours, you get in trouble because nobody can read it continuously, etc. So I said, fine, then I can go and get trained in newborn brain. So I went to British Columbia, at University of British Columbia, and I did 1 year. It was 1 year program, but they didn't have funding. So I ended up doing my another neonatology fellowship just to get funding and doing on top of that neonatal neurology. I was using my research time to study neonatal neurology. And the end of my first year, I went to my program director and I said, I need another year. I don't think 1 year is enough to learn about baby's brain. And also, I wanted to do another fellowship in neonatal hemodynamics. And she thought I am crazy. She said, like, we can't do all that at the same time. And the reason why that happened is when I was studying, my main project was to look at, and that's related to IVH. My main project was to look at the relation between hypotension, low blood pressure, and white matter injury in premature infants.
Hmm.
I do my statistics myself. So for the life of me, I could not find a correlation between any definition of low blood pressure and white matter injury. But while I was doing my statistic, there was always one thing coming up. It was the treatment. The treatment, the use of inotropes was an independent risk factor for brain injury. And
Hmm.
it didn't make any sense for me. So I said, I need to study hemodynamics formally so I can understand brain perfusion. So I did another fellowship in neonatal hemodynamics. Then I came to Calgary and I established the neonatal neurocritical care program. And to your point earlier, when I came here, we launched our program with a mini symposium. I brought key stakeholders in the area from our local institution.
And
Uh,
what year is this, just so we can have an idea of perspective?
that was in 2013,
Okay.
late 2013. So we brought this pediatric epileptologist, neuroradiologist, and my mentor from Vancouver. He actually flew to Calgary to present on brain injury in neonates. And also we had a neurologist as well and myself. So in that meeting, one of our senior neonatologists stood up and that person said, are you trying to tell me that I need extra training and extra service to be able to take care of babies with HIE? Those are hypoxic ischemic encephalopathy babies. When I have been taking care of them for more than 2 decades. And that has been the theme. So then I started to travel across the country to pitch the idea that this is important. We need another training, we need another service in unit and neurocritical care. And I'll get things like at the beginning, we say, how can I help you? You know, when somebody start with, how can I help you? They want to shut the door completely. Or somebody will tell me, quote, I'm not in the position to dictate on people how to train their fellows, so we can't do this. And that was how we started. But I did believe that the brain is the forgotten organ, and there are a lot of things that we can do to improve their care. That's how the story of establishing the program in Calgary.
Yeah. And so from the symposium, and then so essentially what were you saying, that you were suggesting that there was new and additional training that staff needed as a result of your findings? Am I
Yeah,
understanding that
so
correctly?
what we were proposing is to have a separate service first called a neonatal neurocritical care service, and those will be taking care of everything related to the brain. So
Hmm.
that can be preventing brain injury in premature infant, can be managing the babies who have already IVH, those infants with asphyxia, neonatal seizures, the core topics that need subspecialty and extra training to be able to standardize the care, improve the care, make it more consistent. And above all is streamlining definition, because I do believe language and the ability to label is the most powerful
Mm.
tool that human being has. And
Mm.
if we are able to agree on the label, then
Yeah.
probably most of the problem in the world will disappear. And the
Mm.
problem is disagreeing on the label. And that's true even in medicine. I give you the example related to IVH. We we call something as grade one. Somebody else will say, no, it's grade two. Somebody will say, no, this is just a little bit of artifact and brightness. And based on that, it can make or break a life of a patient. And I have examples of that where the report said it was grade four IVH and it was a 25-week, just like interestingly.
Yeah.
And the team read the report. They didn't look at the image and they approached the family, and that was tween two. So it's so interesting. And now that I remember, the family, they talked to the family about redirection of care because this is a 25-weeker and they were 24 plus. And then what still ventilated, they have PDA, so all the risk factors of abnormal outcome, and it's reasonable to redirect the care and withdraw care. And it so happened that I was there and they looked at the images and they told them this is not grade four, this is grade one IVH, and maybe a
Huh.
tiny, tiny bit of blood in the ventricle will make it a small grade two IVH. And there was a big debate among ourselves to the point that we did an MRI just to prove which one of us is correct. And sure enough, it was grade one IVH. And this girl is alive now, and she is totally fine with her sister. And I always look back and reflect and
Yeah.
say how many lives that we lost because of our interpretation, whether they are correct or wrong. And when the problem with looking at the literature, I find when you link bad IVH to mortality, lots of it is diagnosis driven, because I come and I tell you as a parent that this is great for IBH, it's reasonable to redirect of care, and then you trust us and we redirect of care, and then this kid dies, and then we say, oh, great for IVH, increase the mortality when it's self-fulfilling prophecy.
Right.
And so that was the labeling. So one of the reason why we wanted to start this is to standardize the definition. Hypotension was another thing. People will call something hypotension even though the baby was completely stable, and then they will start treating it with inotropes. Where when I understood the physiology, pathophysiology of IVH, I realized that when the IVH happens, the brain is receiving too much blood. They call it the reperfusion phase. So they
Mm.
don't need a big hammer to spike their blood pressure, because if you spike the blood pressure in that fragile area, it's like a highway under construction.
Yeah.
And then suddenly you are opening a big pipe of water and flooding the area and causing the IVH. So that's where the whole IVH prevention bundle, when we put it together, the QI project came together.
You're really what I'm hearing is, you're asking the staff at the NICU to take the time and the effort to like add a whole new, it's almost like a whole new area for them to consider in a completely new way. And like
Correct.
it's a completely new approach, a new way of looking. And I can imagine, that can probably feel pretty overwhelming. You're passionate about it. You're like, no, there's such a difference that can be made here. And they're like, oh, I'm just trying to get my
Yeah.
job done. And yeah.
Yeah, that's so true, and it's against the nature of intensivists. So
Mm.
when I finished my first part of cardiology in BC. I did my second part of hemodynamics in Calgary. And I did lots of echoes, and I would treat babies based on the echo findings. The baby would be completely fine, but you look at the heart, you calculate the cardiac output, you say it's below the cutoff of what's published. So we need to be proactive and treat this heart, and we give them inotropes. And I think we cause harm in those babies before starting the concept of inotropic stewardship. So that was against the nature of intensivists because we want to act, and if we don't act, we feel that we haven't done enough. And the
Mm,
other thing was that against it is this was free, and we always the IPH prevention bundle does not require grants, does not require new equipment. Is the change of approach and change of mindset, and it's hard to grasp on it. And I'll tell you a story about that. But we as humans, we are attached to brands because brands give us status. If I have the Gucci, the Jordan, the things
right.
on, then it's a status. That if I have a Walmart version of a shirt, it means I am cheap. So similarly in medicine, unless you have tagged it with a big grant CIHR and you have a new intervention, there's no way that something just leaving the patient alone that it will make that's a huge difference. And when we
Right.
started this, there was a visiting professor, very famous in the field of neonatal neurology. And as a young staff passionate about my project, I started explaining to him what IVH prevention bundle is. And as a wise man, he let me go. And after I finished, he told me, "Are you trying to convince me by covering the incubators and using pin lights and leaving the baby alone, you can prevent IVH when we have been spending decades and millions of dollars and we haven't been able to do that? Like, just good luck with that." That was
Yeah.
his saying. That was what we were facing, and so that's why when we put this together, we said we need to publish this as soon as possible because if you everybody not everybody, lots of people were waiting for this to fail because it was against what they believed in. Something free cannot work. If it works, you are breaking our belief. So that's where we said we'll have to publish it soon, and that's what we did. When it got published, then everything changed. And what you were talking before we recording things start to expand at very fast rate, and we needed to slow down and make sure that the quality is still there. We are not losing the quality.
So how can you share more about the expansion of the program since those initial publications?
Yeah, so once we got it published, then I was chairing the newborn brain health group also in Canada, the Canadian Unit and Network for a while. So we have implemented it in other centers in Canada as well, and that is the National IVH Prevention Bundle. We came up with checklist of things to do and things not to do. And then an audit tool. We worked on standardizing the definition of audit tool because if you can't audit it, if we are not speaking the same language, there's no way we can test our interventions. And the interesting thing is it didn't work uh, the same way across the centers. And that's something really interesting with quality improvement because it's always about the process. It's not about the protocol. And when we started the IVH prevention bundle, I was just starting my job as a staff, and this big project was put my first task. So I was stumbling, looking through books. What can I read to learn quality improvement? Because I had no idea how quality improvement, how to start a project. So one of the books I read that the recommendation was if you're starting a big project and you want to make a big change, create a parallel with your personal life and make it mirror the change. And there was recommended to pick something that you like but it's so hard for you to do. So that's where I picked running. And my goal was at the end of first year implementation, I will run half marathon, and I had never run. But why I brought running, because running has a perfect match with quality improvement. It it's all about the process. You print out your training schedule for a year. You don't implement it to the point, to the details. One day you are busy, one day you are overdoing it. But as long as your fluctuation around the line is not big and your trend is heading in the right direction and you are respecting the process, and then those terms of tempo and cadence schema, they are so similar with quality improvement. And if people are trying to just take the protocol and implement it, hoping that it will make the change, that's where it doesn't work.
Mm.
It works
So,
when you follow the process, you identify the team, and then you check the process in quick PDSA cycles, and then you come back and you refine your steps. And that's where it extended to Canada, and then it started to pick up elsewhere in the United States as well. I am now the content expert in the for the VON network for the
mm,
IVH prevention. So we are working on IVH prevention in several centers, NICUs in the United States. And then I started get invited in globally in Middle East, in Latin America, talking about the IVH prevention. And the reason why it worked because it was free. Everybody could do it, and that's also made it the hardest because always it's hard to control people. They are source of variability. You need to empower them. You need to work with them. You need to be present. You can't do it from behind your desk and say, okay, here you have the protocol, you implement it, and let's study this after 1 year and prove that it works. It doesn't work that way.
mm. And it doesn't work that way because if I understand you correctly, it's not just doing the protocols. It's it's an it's like a fundamental approach in who their attitude,
Mm.
and correct me if I'm wrong, but it sounds like when because if you're bringing that same you were talking about the discipline of with running that that was impacting your whole mindset. Sounds like mindset shift, but I could be misunderstanding, so I don't want to be putting words in
No,
your mouth.
it's true because if I want to explain a little bit about the IVH prevention bundle, basically what we try to do is to leave the baby alone and allow the physiology to transition slowly. And if you use the analogy of COVID-19, we always talked about flattening the curve. We
Mm,
wanted to flatten the curve, but we didn't want to change it abruptly. And that is also similar in asphyxia. When we cool them and we hibernate them, we decrease the core temperature to 33 degrees for 72 hours. We're trying to slow down the metabolism of the brain, put the brain to sleep until that storm passes. And similarly with babies that are at risk of IVH, we leave them alone in the first 72 hours. We call it the minimal handling, the critical window, and we keep their brain as much as we can in the midline. And then we try not to give them medication as much as we can. So we put strict definition for each intervention and how you intervene and how you test your intervention, whether it worked or not. And I always use the analogy with the team that our interventions are too aggressive for the complicated, delicate system of the human being. Think of it as you're trying to fix your smartphone with a hammer. Even if you are the best carpenter in the world or the best constructor, your hammer
yeah,
doesn't work for your smartphone. So as much as we can hold off and not use our hammer, that will be best. And I think that what made the biggest difference in the IVH prevention bundle is leaving the physiology take care of itself as long as the baby is allowing us.
yeah. So I guess there was, I mean, there was. before your program, if I'm if I'm not mistaken, so there was not the concept of IVH prevention,
No.
right? So I
There
mean,
were, yeah, there were things like medications, successfully giving, using, what's it called, endomethacin, for example, that showed some pharmacy-based interventions that was mainly the IVH prevention, not a holistic packaged approach, everything together to prevent IVH. That wasn't a thing.
yeah. And
Yeah.
so where is the so now it's gone from Canada to the US, now uh global. Are there other areas where you're continuing to explore this area of brain health? And has this new approach, I guess, um, and seeing the positive impact that it's had, is this, uh, given that you strike me as a curious fellow, has this is this continued to evolve and grow for yourself?
Yeah, absolutely. I Then we started looking at asphyxia because asphyxia is another global problem. In the high income countries, the incident it can go 1 to 2 per thousand live births. It multiplied by 10 and more in the low and middle income countries. So we started working on the asphyxia prevention and neuroprotection in babies with asphyxia, and we did similar outreach program where we would go and talk about how to identify those babies, because the challenge with those is you have only 6 hours window for
Mm,
that hibernation intervention to be effective, and most of these babies are born outside the tertiary center. By the time we get to them, then they are outside of the 6 hour window, and even if they start within the window. So one question was, how can we communicate together and make their assessment accurate enough so they can initiate the cooling, we call it, early enough within the window. And second is, how can we make the cooling more effective? Because cooling using the device, the servo control where the thermostat talks with the machine and then it makes their temperature stable. If there's one thing I have learned, the human body doesn't like fluctuation.
mm,
So the one thing that was from the IVH prevention, fluctuation in CO2, for example, fluctuation in blood pressure, fluctuation in glucose, it's bad for the brain. And similarly, in these babies, if we use passive cooling because they don't have the device until we arrive, they
yeah.
just take the cloth, they turn off the warmer, and then the temperature drops. And sometimes it drops so far, and then it goes up and down, and that fluctuation is not good for the brain. So how can we reach fast? And how can we use the machine on the way too? Because many centers they still use passive cooling while they transport these babies. So what we try to do something called real life research. Like, can we study this quickly and be able to publish it quickly and be able to act on it quickly? So we got this outreach program where we that's where innovation came in place, because you got to scale this up. You have to train a very big number of frontline providers, and you cannot. It's not ethical, one, to train them on a sick baby. You bring 100 people and train them. And second, there's no way you can find such baby at the time that everybody is available. So we need to find a solution for it. And that's where we got into virtual reality. We had some of the videos of normal and abnormal examination with a parent's consent. We converted them into animation and then VR, where people can perform the neuro examination using VR. But the problem with VR, two problems I find is, one is expensive, the gadget, and it requires also teaching, is that you have to have a certain computer, you have to the app to be installed. So scaling it up was difficult. So then what we did, we said we'll create a simple doll. We brought one of these commercially available doll, and we basically chop the arms at the joint level, and then we reconnect them with changing the tone of those joint movement. Good babies who are normal, they take the fetus position, so they are stiff and they move around very actively and vigorously. And the ones that they are sick, they are very floppy. So we created those two models, and then we tested it in one of our ex-fellows in India, and she basically ran an RCT, randomized control trial, where we had two groups of nurses. One of them were trained using a traditional method, somebody is training them, and then the other group using the simple doll. And then we asked them to record an independent neuro examination and send it to us. So we blindly assessed their quality of their examination without knowing which group they belong to. And for our pleasant surprise, the simulation was as good as the traditional method and even better. Later on, the retention of the simulation group was better than the traditional group because they were functioning under comfortable, not stressful environment. So that was, we could upscale it using that simple doll. And then we got into AI, and now we are looking at some of the movement assessment, whether the AI will be able to, if you open the camera, and then assess the quality of the movement, just like the technology they use in movement lab and for athletes and running, assessing how they, and can it pick up this encephalopathic babies better than humans. So it will be so fast. Then you can
Mhm.
open up your camera, they look at it, it give you alarm and say, hey, this baby could be encephalopathic. Can you pay more attention to this baby? So that was the first when we implemented it. We implemented it in Calgary and the southern Alberta, and then it became a global again. It went from Calgary to around the world, and we start to talk about this innovation and outreach. And we have some. I'm involved in some of the programs in Syria and other areas in India where you do all this tele ICU and assess the cases. So and from then we worked on PHVD, for example. We did talk about shunt before we start recording. Question came now, we were able to decrease it by more than 50%. But what about the other 50%? What about those who had IVH? Are we leaving them alone? Like we say, okay, we couldn't prevent it, so
Right.
you are by your own. We can't do that. So then what happened is for those babies with IVH grade 3 and have post-hemorrhagic ventricular dilatation or hydrocephalus, the problem with them was, again, the labeling and definition. What, at what stage, what threshold should we intervene? And until this day, there's no agreement between neurosurgery and neonatology.
I
The
will I will
neonatology.
tell you, our daughter was she was about at this point about 32 weeks, and we said to the neonatologist, our daughter's her head circumference, this is not right. Something does not look right. And they said, don't worry about it. It's just catch-up growth. I'm like, catch-up growth.
I mean,
Okay.
that makes me sad.
And then,
I
and
think.
like I said, then we're home for a couple of weeks, and the pediatrician was like, "This is something wrong, some yeah."
Yeah,
Okay.
yeah. That's for me. It's always humans are not statistics, and when I present these cases and make the argument for one intervention, I say one is too many. It doesn't matter if you lose one child, that's like you lost all of them. It's too precious to lose. So I refuse to take, okay, though we improved and we only 10%. Those are not numbers. For that family, it's 100%. It's
Yeah.
not 1%.
I do remind parents that because they can begin to read the statistics, of how many babies born early are blind or have this, cerebral palsy, have all these different uh, comorbidities. And I remind them, your baby is one, is a
Hmm.
unit of one. And so none of those statistics, uh, it will, it's gonna, you're gonna do everything that you can, but you do not have to worry about the statistics, right? Treat that baby.
And to that. to that point, I always talk with the families about the label locked minds and embracing the uncertainty because
Yeah.
I tell them not knowing keeps us going. And
Yeah.
if I know that today is the day, if I commute to the work, it will be the day I will have an accident, I will camp in my house and
Right.
probably let
Yeah.
my beard grow and just be a monk or something. Because,
Right.
but not knowing keeps us going. And if
Yeah.
we stuck on those risks, we develop something called label locked mind. Because as parents, I am a father of three, we cannot but worry. So then we start, our mind get locked on that level. Say, my baby is at risk of cerebral palsy, and if he or she is within that window of the spectrum, but the neighbor child walked 2 months ahead of my child, and then I say, oh, this is because of the cerebral palsy, and
Right.
then in our mind it prevents us from pushing our kids. And the single things that improve the outcome is the parents' involvement and stimulating, interactive, loving environment is better than any intervention we have ever invented.
Oh, that's a good, and it's free.
Yeah, yeah.
That's a great reminder. I am curious before we finish our conversation. You did mention how that that experience where there was a disagreement on the, is it a grade one, grade four? Is that is that still a challenge? Is part of it a challenge just because of where technology is today and being able to actually see the bleed, or has there been development in technology and imaging that you're able to have a clearer picture and and have better agreement across multiple people looking at the same
Mhm.
information?
It's an interpretation problem more than technology. So what we did for that, we created a task force of a neonatologist and neuroradiologists in Canada. And then I invited a couple of experts from Europe too, because I knew their approach is more aggressive and more proactive in imaging and interpretation. And what we did, we tried to identify the sources of variability, just like that case. What are the sources of variability that make us disagree, and can we come up with consensus? So
Yeah.
one of them was grade three versus grade two, the brightness, how much bright is too bright to call it blood versus artifact, etc. So we identified 5 areas of variability, and we start working on it for about a year. We came up with a consensus. We published that and we made it available for free. And then we took that and we made it an application, a free application where you can download the app and you answer questions. With each answer, it gives you an example of how the image will look like, and at the end would tell you this is the grade of the IVH. Now that is well and good when you use it as an outcome measure, because you need the outcome measure to be as clean as possible to be able to test your intervention. Because if you are not, we are not using different yardstick to measure interventions, there's no way if it can cross from mild to severe. If it's grade two, it will fall in the category of mild to moderate. If it's grade three, it will be as severe. And similarly with grade four, if it's echogenicity, it will be fine. If it is grade four, it will be severe. So suddenly your statistics are inflating. And if you are testing an intervention, you can get false reassurance if you are not interpreting your outcome correctly, or unnecessarily frustration if your intervention is already working. So that is the first step is working on the outcome. So then uh, we implemented that, and it has becoming much better in that perspective. But I always tell my fellows is just in your mind separate the reason, the purpose, the goal why you are reading this cranial ultrasound. Is it as an outcome measure? Then being abstractive and really clear and systematic is extremely important. or are you talking with the family? Because when you are talking with the family, it's important to be descriptive, because there is within the grade 4, or what we call it now, periventricular hemorrhagic infarction, there is a spectrum. There is tiny grade 4 and there is massive grade 4, and the outcome of these kids will be very, very different. You have to look at the image, you have to show the parents the image, you have to explain, and you have to come back and explain, because those conversations, I can tell you, we are doing some of the qualitative studies about a different subject. And couple of parents, the first two parents we interviewed, the first thing they mentioned by themselves, how traumatic it was when they heard the results of cranial ultrasound. One of them was suicidal, and one of them still having PTSD from it. The study was completely not about IVH,
Right.
but they presented it was so impactful.
Yeah. Yeah. It is not, I appreciate the, how difficult some of the conversations can be with parents. We are hoping for the best. We're trying to, and there's just so much, like you said, there's so much that is unknown, and you see what you see, you interpret what you interpret, and there is just so much that is unknown, and
Mhm.
I'm certainly grateful for that. Um, I am grateful that you decided not to just open up your clinic and buy a house. And although I'm sure that would have been lovely for you and your family, but for all the parents of premature babies, we're grateful because there's people like yourself that are passionate and want to make a difference. You recognize how what a overwhelming experience and situation this is, for the baby and for the families. And so having knowing that there are people like yourself that are, like I said, passionate about doing the work that you're doing, fills my heart, right? It fills my heart because we parents, unless you start a nonprofit and keep doing having all the conversations that I've been fortunate to have, you would have, and gone to all the conferences I've gone to, you'd have no idea of sort of what's happening every day, all the time in the background that is, impacting, I say overall for the good, um, for our babies and for the families as well. So, again, I want to thank you for spending a little bit of time with me today. And I know our families are going to find our conversation fascinating. We will be sure and include links to your LinkedIn profile because you do, and there may be if there's other places for our parents to be able to learn more, we'll be sure and include that. But you've shared a lot of really great information and resources. So again, I really appreciate your time today.
Thanks, Nicholas. I'm equally grateful. So one of the best thing I have had in my career, this personal relationship with parents, with the babies, with colleagues, while we are discussing and trying to solve some of these problems. I appreciate it.
You bet.
Thank you.